Eddie woke you up. I hope not to put you back to sleep. I was assigned to speak on the topic of shortcomings of current cardiogenic shock definition. I think it's a nice segue from the discussion we just had. I'll jump right into it because there's not a lot of time. I have no financial disclosures. So just to broadly define cardiogenic shock, I think we could define it as end organ hypoperfusion secondary to pump failure. More specifically, we can define it as systemic hypoperfusion due to inadequate cardiac output despite adequate circulatory volume. This might be secondary to myocardial, valvular, or conduction abnormalities, or even pericardial diseases. It's important to understand that acute myocardial infarction accounts for about 80% of patients that present with cardiogenic shock, and this is the population that has largely been studied in clinical trials. Our recognition of cardiogenic shock and the spectrum of severity goes back more than 50 years. This paper from 1967 documents a 2-year experience with 250 patients admitted with acute myocardial infarction. And the authors describe what's become known as the Killip classification system. And they knew at that time that those that presented with the most severe form of cardiogenic shock, marked by hypotension, as you see there, and signs of peripheral malperfusion, they had an in-hospital mortality that exceeded 80%. And while we've made some progress over the years, this Killip Class 4 classification has remains clinically relevant because it largely has informed every clinical subsequent trial on cardiogenic shock. So let's look at how we've defined cardiogenic shock in the modern era for the purpose of clinical trials. Here's the landmark shock trial that was just alluded to, examining the impact of early revascularization on patients presenting with cardiogenic shock and acute myocardial infarction. Here's how they've defined it. It's a modification of the Killip Class 4 classification. You can see largely marked by hypotension with some degree of end organ hypoperfusion. They also asked for pulmonary arterial catheter criteria to document low cardiac output and congestion, although this wasn't necessary if congestion was evident on imaging. And as we know, at 30 days, there was no difference in survival, but there was a significant benefit to early revascularization when they looked at 6 months, and that persisted out to 6 years. So it's largely the results of this trial that has changed the way we manage patients worldwide admitted with cardiogenic shock and acute myocardial infarction. The impact of these trials is really tremendous, and it's imperative that we get it right. Interestingly, the vast majority of patients in both groups were treated with an intra-aortic balloon pump. So let's jump forward to another landmark trial, the SHOCK 2 trial, looking at the impact of intra-aortic balloon pump. About 300 patients randomized to either a balloon pump versus no balloon pump. Here's the original SHOCK trial definition. Here's the SHOCK 2 trial, very, very similar, again, mostly marked by the presence of hypotension. They also allowed for a very modest serum lactate as evidence of end organ hypoperfusion, and importantly, they did away with the need for a pulmonary arterial catheter criteria. And as we know, there was no difference in survival at 6 months, although some have argued that perhaps these patients weren't sick enough to derive a benefit. It's these results that have resulted in the downgrading of intra-aortic balloon pump in current guidelines. There's been a host of other trials looking at other forms of percutaneous mechanical circulatory support systems randomized against a balloon pump. These inclusion criteria are very similar to the SHOCK trials, some requiring a pulmonary arterial catheter, others not. Here's the Impella 2.5, 13 patients each arm, no difference in survival when compared to a balloon pump at 30 days. Here's the more powerful Impella CP, no difference in survival, 24 patients each arm, no difference at 30 days or 6 months. Not to be left out, here's the Tandem Heart System, 20 patients each arm, no difference in survival at 30 days. So what's going on here? I think we have all these therapies that we know work, that we've seen work time and time again, but when we subject them to what we think are well-designed, randomized, prospective clinical trials, they don't perform. Well, I'd submit that it's possible that, indeed, they don't work. It's also possible that they do work, but that the treatment effect is not as big as we think, and so our studies are just simply underpowered. And it's also possible that we're looking at the wrong patient populations. So our modern understanding of shock recognizes 4 distinct buckets, and we think as astute clinicians, we're pretty good at categorizing patients and putting them in the appropriate spot. But we recognize that in clinical practice, there's often a mixture, and that patients present with a mixed picture. And it can be very difficult to distinguish amongst these, especially in the absence of invasive monitoring. We also know that cardiogenic shock has more than one phenotype, and not every patient presents with a classic cold and wet physiology. And so we need more granular classification systems of the cardiogenic shock spectrum to better tailor our therapies and to better predict outcome. So what about outcome? We have a lot of prognostic scores. These have been around for decades. These were largely developed to predict ICU mortality in a mixed population of patients, although some have been modified over the years to be more specific. We have those last two have been developed for specifically the cardiogenic shock population. And this is going to segue nicely into Dave Barron's talk, which is going next. Here's the card shock score that you just saw presented in Eddie's slide. It's 7 clinical variables that are easy to identify. You have a risk score with a maximum score of 9. You can see that you've got good mortality discrimination between groups, but you'll also recognize that the number of patients at the very low scores and very high scores is quite low, and this has not been validated. Here's the SHOCK 2 score. This was developed in the SHOCK 2 trial data set, and it was validated in the SHOCK 2 registry. 6 clinical variables, again, a maximal score of 9 that can easily identify a low, intermediate, and high-risk patient populations. And this might be useful, but it's not been validated outside of acute myocardial infarction patients. So what we need is an objective system to better classify our patients into distinct risk groups so that we can guide our decision-making and inform patient inclusion in future clinical trials. So I'll just summarize that cardiogenic shock is not binary, but it's a continuum. Current definitions does not discriminate severity, nor does it discriminate the etiology. That cardiogenic shock patients are heterogeneous and may respond differently to different treatment, and that prospective trials are needed to better evaluate invasive and non-invasive therapies in specific patient populations at more defined stages of cardiogenic shock. Thank you.
Questions? You gave an elegant presentation, and I think I'd love to steal some of your slides, but they're wonderful. My specific question, when we look at the national Impella IQ database, 40% of the shock patients are acute MI shock. So actually the majority of use of this device in the U.S. is for not acute MI. It's cardiogenic shock, but it could be myocarditis, it could be Takotsubo, it could be a variety of other causes. So I wonder, when you're talking about defining, wouldn't we advance the field a little bit to kind of talk about acute MI shock in one bucket and other kinds of shock? Because the pathophysiology may be different and the outcomes and the treatments may be different.
Yeah. I think that's what I was arguing for, is that I think we need to separate those patients out because we treat cardiogenic shock like a single bucket, and it's not really a single bucket. There's a lot of discriminatory differences between those patients, and I think studying them as a group, especially with small numbers, we're prone to errors.
Any comments from the audience? Questions from the panel?
Along the same lines of different etiologies in cardiogenic shock, at least 2 major pathways, STEMI, like acute MI, and heart failure exacerbation, which may be either acute or just development progression of chronic heart failure. So probably indeed enrolling patients along the separate baskets, along the separate groups would make more sense than just. Another consideration, we usually think that cardiogenic shock is due to left ventricular pump failure. But you know, in massive pulmonary embolism, it is a cardiogenic shock due to gross right ventricular failure. They respond completely differently and more favorably to mechanical circulatory support, primarily to VA ECMO circulatory support. So there should be a distinction, like what patients we are talking about.
Yeah. Most of those trials do separate out the pulmonary embolism failures, but absolutely right. And I do agree that exacerbation of chronic heart failure is very, very different from acute myocardial infarction for all the reasons Eddie mentioned, with the inflammatory milieu that goes along with the other.
Since, to be provocative, since we all have representation from America and Europe, the American guidelines in the definition of shock include blood pressure. The Europeans don't include blood pressure. So I would like to see a debate amongst panelists to see whether it should be included in the definition or it should not be included in the definition.
It should.
I'd like to sort of, again, being provocative and say that David's going to give us a spectacular overview of the shock criteria, which are not, there's no invasive hemodynamics, but I think if we're going to move the field, we have to use some common metric of hemodynamics. If you have a patient that has a CPO at baseline of 0.3 and another one that has a CPO of 0.9, their blood pressure is still 90. But one of those two is far more disease, far more at risk, far more likely to die. And so if we're going to be comparing, you have to have some sort of apples-to-apples comparison. I wasn't aware of the shock 2 that took out the SWAN need, which I think is really interesting because that trial, of all the modern trials, had the lowest mortality. And I think it's likely taking out the SWAN and mandating a true definition of cardiogenic shock hemodynamically probably resulted in recruiting a lower risk subset. So you can't compare balloon pump shock to culprit shock. There's almost a 10-point difference in survival with them doing exactly the same thing. Any other comments?
The issue for me remains, when I looked at this data, the problem is that we have a small number of patients. To enroll in these trials, it's taken forever and all that. But the reality is there actually are enough patients. If we had some way to kind of organize this and be able to look at the data in a broad way, then you're going to hear me talk a little more about this sort of AI perspective. But if you used a big data AI concept, then you could look at all the contributors that are involved. We use blood pressure as a trigger to kind of get started in America to treat the patient because we have to do something in front of us. But the real issue is if you think on different levels, you've got hemodynamic variables, and then you've got metabolic variables, and you've got all these other variables that we're eventually going to be able to identify. The question remains, what's the coefficient behind each one of these in terms of the rise and fall of their significance and what you're trying to treat? We don't have a way to do that, but we can get there if we're, all work together to try to look at things in that type of dissective, kind of multi-scale kind of way. It's not a solution for right now, but it certainly could be a solution over the next sort of 5 years if we take that approach.
I think that is important to define because, like Dr. Neal said, that early shock treatment is what is going to make a difference. But the problem is for the vast majority who are not dealing with shock every day, like peripheral shock centers, they focus on the blood pressure. And that becomes a surrogate for therapy. And the only thing they are increasing the pressures is based on the blood pressure. So they keep adding one pressure to the next, to the third, to the fourth, till the metabolic thing starts screaming. That's the time they realize, okay, let's send the patient to a shock center. So I think we have done a disservice by putting a blood pressure marker on diagnosis of cardiogenic shock, and that, without intent, has become a surrogate for a treatment target.
And then we're dealing with the detrimental effect of catecholamines because, like Dr. Bill O'Neill just said, it is pheochromocytoma, it is Takotsuba, it is catecholamine surge, same as subarachnoid bleed, it is myocardial dysfunction due to stress-induced cardiomyopathy, iatrogenic in this case.
Okay,
One more question.
Just a comment, the back of Brussels. I think that we need to dissect a little bit our definitions. I mean, the flow and pressures are probably something that we can easily, and we showed very nicely, we can easily control it. I mean, you put any support, mechanical support, you have adequate flow. I mean, you have normal flow. You put any vasopressor, any whatever, you have the good pressure. Nevertheless, you have 50% mortality. So it is not the flow which is leading to the death. This is, in the cardiac shock, I mean, you define the cardiac output because you need to make the difference between septic shock and cardiac shock. Agreed. So that's for the cause of the problem. But the consequences, we do not pay enough attention in our definitions. We have a little bit of a lactate there, we have a little bit of other, but we still lack very good indices of tissue hypoperfusion to really categorize between something which is mild and something which is more severe. And that's why perhaps in our trials, when we just use blood pressure and cardiac output and feeding pressures and whatever, we just are mixing very severe shock and very mild shock in the same umbrella. And so we randomize patients, but we do not randomize exactly the same patients.
I absolutely agree with you, but I will point out that the more granular you try to get, the more disagreements you're going to get, and the more difficult it is to document it, it just becomes insurmountable with creating a clinical trial that people are going to be able to enroll in. So it's a really difficult thing to do to get everyone to agree upon. And I also agree with you that early intervention is very likely the key, but when you intervene early, the risk-benefit ratio is very different. that's something that we need to subject to a clinical trial, but it very well may be that we're wrong, that if we're too aggressive early on, we're going to hurt patients and not help them. So it's something that I think is also true, but may not be.
Thank you very much. That was a wonderful overview.